When most people think of cancer, they imagine a tumor you can see on the scan or feel with your fingers. But that visible lump is actually the late stage of a very long process. A solid tumor that's about 1 cm in diameter can contain hundreds of millions to around a billion cancer cells. At that size, conventional scans like X-ray, ultrasound, CT, MRI or PET scans usually start to pick it up. The problem? It often takes 10 to 12 years for cancer to reach that point. So by the time a scan detects something, the cancer process has already been silently evolving for years. So how cancer really begins? Cancer begins when a normal cell's DNA becomes damaged or mutated. This can result from chronic inflammation, toxins, oxidative stress, radiation, poor nutrition, or even long-term high insulin and glucose levels. This is called initiation in the cancer timeline. Your immune system is supposed to act like security. Healthy immune cells can recognize this cell is not normal and destroy it. Cancer finds ways to hide. Some early cancer cells can switch off the "I'm dangerous" alarm signals so the immune system doesn't attack them. Now those abnormal cells start multiplying. They also begin to reprogram their environment, by changing local metabolism, blood supply, acidity, growth signals, etc., creating what scientists call a tumor-friendly microenvironment. We sometimes call this the tumor's internal terrain. This terrain is influenced by lifestyle and internal chemistry, such as constant high blood sugar and high insulin, chronic inflammation, low oxygen in tissue, and toxins buildup. All of this can switch on cancer-promoting genes through epigenetic changes. This stage, called the promotion stage, can silently continue for many years while the cells are still too small to be seen on the scan. As the growing cluster becomes more aggressive, it learns dangerous skills. It invades nearby tissue. It builds its own blood supply. It breaks off and travels the bloodstream as circulating tumor cells. These circulating tumor cells seed new areas. In other words, it metastasizes. This is now clinical cancer, the stage that usually triggers diagnosis, treatment, fear, and even insurance claims. In RGCC's cancer development timeline, the early stages, that's initiation and promotion, can stretch over 10 to 12 years before you get a mass big enough to be detected with traditional imaging. The fast, dangerous phase, spreading and relapse, can then happen over just 2 to 3 years once those cells become mobile and invasive. That's why everything looked fine last year can suddenly turn into stage 4 shock this year. When cancer cells learn to move, they do something critical. They enter the bloodstream. These are called CTC, which stands for circulating tumor cells. Here's roughly what happens. Tumor cells break away from the original tumor. They enter nearby blood vessels. They survive in the blood and travel. They exit somewhere else and can start a new tumor in another organ, in the liver, lung, in the bone, brain, etc. Metastasis or spread is the main reason most cancers become life-threatening, not just the size of the original tumor. So, being able to detect, count, and study CTCs gives us extremely valuable information about what the cancer is doing right now, even if scans look clear. RGCC is a laboratory approach that focuses on live circulating tumor cells from a patient's blood sample. In simple terms, instead of only asking, do we see a lump? We can now ask, are there cancer-like cells already in circulation? How aggressive do they look at the molecular level? What are they sensitive to or resistant to? Some RGCC panels can isolate and count CTCs, analyze tumor-related gene activity and protein markers, test those cells against various treatments to see what looks most effective for that patient's cells in the lab. This includes certain chemotherapy drugs, some targeted agents, and selected natural compounds. This is a game changer for two groups of people. The first group, those who already had cancer, especially those already declared in remission. Even after surgery, chemo, or radiotherapy, tiny numbers of surviving tumor cells can still circulate in the blood. Traditional scans may say no visible tumor, but if CTCs are still present and persistent, that suggests the process is still biologically active and there's still a relapse risk. That means you need monitoring and possibly active personalized intervention. not just wait and hope. The second group, people at high risk. Those with strong family history, those with certain genetic predisposition, those with history of high exposure to carcinogens, etc. For these people, the question is not, do you have a lump? The question should be, is there early tumor biology happening that we can do something now? This shifts cancer care from reactive to proactive. In other words, instead of saying, oh, we found a mass, now we fight for your life, we change the narrative to, we see concerning signals early, let's intervene before it becomes a mess. So, has cancer treatment changed? Well, yes and no. Surgery, chemotherapy, radiotherapy are still absolutely part of standard cancer care. They save lives. But the philosophy worldwide is evolving. Modern oncology is no longer only about poison, burn, cut. Increasingly, it's about enhancing immunity because scientific evidence shows cancer as an immune recognition failure rather than just an anatomical disease. Treatment strategies such as immunotherapies, like checkpoint inhibitors, try to wake the immune system back up so it can recognize and attack cancer cells again. Some cellular therapies are literally training or re-engineering immune cells to act like guided missiles. Also, there's a growing focus on making the body's internal environment less friendly to tumor survival by improving metabolic health, inflammation control, hormone signaling, etc. Cancer treatment is evolving from one-size-fits-all chemotherapy protocols toward personalized, immune-guided, and targeted therapy. By understanding each patient's unique tumor biology, doctors can select the most compatible therapies, whether conventional, integrative, or supportive, while reducing unnecessary toxicity. What's the real danger here? Late action. Too many people only act when there's already a detectable mass, when it has already spread, when symptoms are already obvious. By that point, treatment becomes longer, harsher, and more expensive. The emotional cost to the family is higher and relapse becomes a constant fear. Waiting for a big tumor is like waiting for a heart attack before you care about cholesterol. We don't manage heart disease like that anymore. We shouldn't manage cancer like that anymore. The new message we want the public to hear. Number 1, cancer starts long before a scan can see it. Number 2, your immune system is deeply involved. Cancer is not just bad luck. Third, circulating tumor cells can be detected and studied through advanced testing. Fourth, tracking these cells can guide more personalized, targeted strategies instead of guessing. Fifth, the earlier you intervene, the more options you have, and the less aggressive those options need to be. Early awareness is not fear-mongering. It's buying yourself time. So what can you do next? If you have a strong family history of cancer, if you've had cancer before and want to monitor relapse risk, or you're simply the kind of person who prefers prevention over crisis, then you should sit down with a clinician who understands both conventional oncology and functional immune metabolic support. This is not about panic. This is about acting early before cancer takes root.